So before we get into the specific drug therapies, of course, I want to make another comment about the role of weight and lifestyle intervention, because no matter if you enroll somebody into a clinical trial or you decide to give them a drug, the baseline and the background of all therapy absolutely must include lifestyle modification. And I know for those of us who practice as internists or any other specialty, we are all literally inundated with the obesity epidemic. And I think the theme throughout many of the talks today in gastrointestinal disease is the importance of obesity management as the backbone of any therapy for gastrointestinal disease. And of course, NAFLD is no different. The hard part, of course, is getting our patients to lose weight. Losing weight is not easy. I've tried to lose weight. It's not easy. I'm sure many of you have too. So I think what's really important from a prevention standpoint is this is a study that we actually did a couple of years ago. We looked at data from the coronary artery risk development in young adults, or the CARDIA study. This is a prospective NHLBI funded cardiovascular cohort study that enrolled over 5,000 Black and white young adults in the mid-1980s, and they have now followed them for 35 years. And what we did is we looked at a subset, about 4,400 of these patients who had data at baseline and then also went on to have CT scans of the liver done 25 years later at a mean age of 50. And we looked at their change on the y-axis here in body mass index from young adulthood into middle age, and what was their odds of having prevalent fatty liver disease in midlife. And what you can see is that the data told us there were 4 different patterns in the data, that there are 4 different sort of trajectories that a patient could take over time in terms of their weight. They could stay stable, they could moderately increase their weight over time, they could have a high increase, or they could have an extreme increase in their body mass index. And what we showed was that there was a very nice epidemiologic increase in terms of the odds of having NAFLD in midlife based on how rapidly your body mass increased over time. And the most important thing is you look at what we adjusted for in the model is this was independent of both where they started from, so independent of their baseline BMI, and independent of where they ended up. So to put it in plain terms is if you were obese at age 25 and you just maintained that same level of obesity over 25 years, you were less likely to develop NAFLD than somebody who was normal weight at age 25 and then gained, 30, 40 pounds over adulthood and ended up in an obese category. So really important when we think about prevention and we think about the messaging about lifestyle intervention, that weight loss, of course, is important, and we'll talk about weight loss and the impact of weight loss. But weight maintenance is something that as practitioners, just getting somebody to not gain any more weight may actually move the needle on their disease, especially if we can intervene early in our primary care clinics when we're seeing these young adults very intermittently, because they often don't come every year, to try to focus on this as an important prevention effort. So what about degree of weight loss? What do you tell patients? What's the goal? So this was one of the first studies that was done. This has been replicated several times now. This was a nice study out of China. They randomized 154 patients in a one-to-one fashion to an intensive lifestyle intervention with a primary endpoint of remission of fatty liver, and this was detected using MR technology. 64% in the intervention group resolved their NAFLD within 12 months of the intervention, and 20% in the control group, so again, that placebo response, resolved NAFLD here as well. So you can see a 44% reduction in the risk of NAFLD. And you can see here on the axis here that as you had increasing percentage of body weight loss from baseline to 12 months, you had a greater likelihood of resolution of NAFLD. So if you lost greater than 10% of your weight, 97% of patients completely resolved the fat in their liver. This has also been replicated histologically as well. So this was 293 patients who had biopsy-proven disease, and in terms of the primary endpoint at this point, it was that co-primary where they looked at resolution of steatohepatitis, and you can see the more weight that you lost here in the yellow circles, the more likely you were to have resolution of NASH. And then the same thing with fibrosis. There was, of course, that placebo response where some patients who didn't lose weight had regression of fibrosis, but you can see the trend here in the line was that if the more weight you lost, the more likely you were to actually resolve fibrosis. So it improves both pathways, inflammation and fibrosis. However, it's not a guarantee. Because what you can see here is if you look at above the median, look at these people. Some of these people lost 14, 15% outliers of their weight loss, but they still didn't resolve their NASH. And even in people who didn't hit that 10% mark, there were people whose fibrosis got better. So again, the dynamic nature of this disease can be very difficult to assess who's going to be a weight loss responder and who's not going to be a weight loss responder. But we tend to counsel patients that the data overwhelmingly supports that if you can lose at least 5% of your body weight, that you have a reasonable high likelihood of improving your steatosis. If you can lose 7%, you're likely going to improve your steatohepatitis. And if you can lose 10%, which I think is the best benchmark we can give patients, that you're very likely to potentially either halt progression or potentially even regress some of your fibrosis. So what about bariatric surgery? Of course, this is a very hot topic now in 2021. We've learned so much in the past 20 years about the role of bariatric surgery in terms of metabolic outcomes, improvement in mortality, cardiovascular risk, and other things. And this was a very nice study that showed that the NASH disappeared in about 84% of patients at 1 year with no significant recurrence of disease between 1 and 5 years after bariatric surgery, okay? Fibrosis, which is shown here in the center in the brown bars, began to decrease 1 year after surgery and continued to decrease over the 5-year period over time. So that at 5 years after bariatric surgery, 56% of patients, so as the white bars go up, this is people who had no fibrosis on biopsy, 56% of patients now had no fibrosis on biopsy. This is a huge impact, okay? And this is just showing you what this would look like in terms of histology in one sample patient. You can see at baseline all these big white dots is severe steatosis and NASH. 1 year later, you can see that the fat has nearly resolved. There's only a few small white dots on this biopsy. And then 5 years later, look at this. This is basically, hepatology aside, this is almost a nearly normal appearing liver. So really impressive outcomes with long-term bariatric surgery. Now, of course, not all of our patients are going to qualify for this intervention, but even though currently in 2021, NASH is not an indication in and of itself for bariatric surgery, as we already pointed out, many of these patients already have multiple indications for bariatric surgery. And so if NASH is present, I can tell you as a hepatologist that I very much talk about bariatric surgery as a therapeutic option and talk about the importance of considering that, especially since most of these patients have failed weight loss interventions and other interventions in the past.